and welcome to the discussion today on a CLL and the evolving BTK inhibitors landscape. I'm Farrukh Awan. I'm in UT Southwestern in Dallas, Texas, and we'll be talking about some of the recent updates in CLL and some of the issues and try to come up with a way that can help us sort through the issues related to BTK inhibitors. So just a couple of housekeeping things. Feel free to interrupt, ask questions, please. If you want to go on camera, that's fine. And then if we can put other stuff to silence during the duration of the event, that would be awesome. And the more discussion we have, the better it is. For me, it makes it more interesting. So these are the two objectives for the meeting today. We'll talk about the current treatment paradigms for the management of patients with CLL. You're probably well aware of everything that's happening in the field, and we'll just talk about that. And then we will talk about some of the newer BTK inhibitors, the newer agents, and there's obviously a lot of new drugs that are being approved in that setting. So we'll see how we can select patients appropriately and some practical consideration of how and when we use those drugs. These are my disclosures. So this is a very simplified version of how we think about treating a patient with CLL in the US. So I'm giving you sort of a biased opinion, and I understand that other places in the world might disagree with this approach or may do things differently. That's perfectly reasonable and normal. It all depends on the kind of limitations and approvals that every country or every region in the world has. So again, take it with a pinch of salt. This is what I have access to. This is how I decide to proceed with treatment for CLL patients when I'm thinking of treatment. Obviously, if the patient does not have indications to treat, we observe them. And right now, really the only two things, and possibly now an evolving third aspect, is the IGHV mutation status. But really, prior to that, we had two big distinguishing features. One was 17p deletion or TP53 mutation. So if the patient has that, we always start with a BTK inhibitor in this country. And that's basically either acalabrutinib with or without obinutuzumab and zanubrutinib. For patients without that, venetoclax obviously becomes an option. We tend not to use venetoclax in our 17p deleted patients upfront. It's not wrong necessarily. This is, again, just a preference because of the slightly inferior outcomes in those patients. But basically, we've moved on from ibrutinib. We don't use that anymore to start off with, and we either start with acalabrutinib or zanubrutinib. And like I said, at any point, if there's any questions or concerns, feel free to interrupt. This is the very, again, slightly simplified, much simplified version of how we think about when you have treatment for relapse disease. If somebody has relapsed CLL, again, the same principle here is if the patient needs treatment, those are the patients we treat. If the patient doesn't need treatment, we don't treat them. And then the subsequent line of therapy is based on what they had in the frontline setting. So if they had a prior BTK inhibitor, we go with venetoclax. If they had prior BCL2 inhibitor, we go with a BTK inhibitor. And if they've had prior chemotherapy, because patients still are getting some chemotherapy, those are the patients in which all three of those options, zanubrutinib, acalabrutinib, and venetoclax, are reasonable options. A small caveat here is that if you have had a prior BTK inhibitor, there's two types of patients. One of those patients has intolerance, and they stop because they have side effects. And the second is the one who's truly progressing on BTK inhibitors. So in that case, if the patient, let's say, was on ibrutinib and now had toxicity and they're progressing a few weeks, few months later, in those patients, switching them to another BTK inhibitor is a perfectly reasonable option. So for example, if they're having toxicities with ibrutinib, we can easily switch to acalabrutinib. If the patient is on a BCL2 inhibitor like venetoclax and they finish 12 months of therapy or 24 months of therapy or whatever situation you had and has not had a prior BTK inhibitor, in those patients, it's still debatable how long a remission you need before you can reuse the venetoclax. I know in some countries you are only allowed to use venetoclax once. In the US, you can use venetoclax however many times you want. So it's not an issue. So that's when this issue comes up. If I had a 3-year remission or a 2-year remission, is it okay to use venetoclax again? And the answer is we don't really know, but based on some of the earlier data that we have, and also with chemoimmunotherapy, If you had a 3-year remission, definitely you need to have at least a 2-year remission to expect that the venetoclax retreatment would work. So that's how we do it. You can retreat the patient with venetoclax, and in a lot of cases, we switch from venetoclax to BTK inhibitor. So that's kind of how we think about patients with CLL when we are managing them. There is also this question about true progression on BTK inhibitor. In those patients, we definitely switch to venetoclax. And the idea is, again, we don't stop the BTK inhibitor. We try to overlap it with the venetoclax. Otherwise, if the patient is truly refractory to a BTK inhibitor, and if you stop the drug, the disease tends to flare up, and it makes it much more challenging for venetoclax. So that's kind of the nutshell of what we will be talking about, and I will try to justify why we feel like this and why we treat our patients like this. So again, as I said before, I'm talking from mostly a US perspective, but I'm happy to look at and see what you guys feel about this. I understand that a lot of patients in the world and in the community, even in the US, still get a lot of chemotherapy. But in our opinion, if you have access to a lot of these drugs, cost issue aside, chemotherapy has no role for CLL. It has been shown now clearly, even in the low-risk group, even in the high-risk group, that you have a survival advantage when you use ibrutinib with rituximab in the ECOG study, for example, and as compared to chemoimmunotherapy, even with FCR or even with bendamustine rituximab. So really, as it stands right now, is chemotherapy an option? Possibly you can justify it in some patients. For the most part, I think as a field, we've decided to move on from chemo because our patients are doing so well. We feel that there's small risk of 9% or 10%, whatever risk of secondary malignancies and MDS is not worth it for a sustained remission in a small subset of patients with mutated IGHV treated with FCR. The other reason why we don't recommend chemotherapy is that if you're making the argument that IGHV mutated patients do really well with FCR, in this country, in the US at least, only around 10 to 15%, maybe 20% of the patients even get tested for that. So the fact is that the vast majority of patients are getting chemotherapy without even knowing their mutation status. That's the first point. Number two, the most common chemotherapy used in the United States. So again, even less reason to justify the use of chemotherapy in any setting for CLL. So this is again the Alliance study that I alluded to. This was a crossover design. So patients who had bendamustine when they progressed went to ibrutinib. Obviously, that study will not have a survival advantage easily shown because of the crossover design. But even with this study, there was clearly a benefit of using bendamustine or using ibrutinib over bendamustine. So right now we have 3 BTK inhibitors, and then we have a 4th one that was recently approved in the US for patients who have failed these 3. But for the sake of discussion, we will just keep ourselves to ibrutinib, acalabrutinib, and zanubrutinib, and I'll talk about pirtobrutinib at the end. But 3 BTK inhibitors, they're all very effective drugs, and by that I mean that they are all targeting the BTK receptor very effectively. They also have a very low IC50. So the binding of the ibrutinib or acalabrutinib or zanubrutinib to its intended target, which is the BTK, is awesome. So there's really no debate about that. They're all very effective drugs. The problem really is that there is a lot of off-target effects, and a lot of these patients have side effects from this chemotherapy, or if you want to call it chemotherapy. But basically, these treatments can cause a lot of different side effects, and that's based on the fact that they are targeting different kinases off target. So ibrutinib looks like it's the most dirty, followed by zanubrutinib, followed by acalabrutinib, and that kind of explains their side effect profile. So this is how we are trying to come up with a way to make a decision about which one of these to use. But I don't think there's a lot of debate about which one is the better drug. I think they're all pretty good drugs. I don't think that there's one better drug than the other, and we'll talk about some of the comparative data in the relapse setting and what the issues are with that. It's really the argument really right now in the field is about toxicity. This is the Elevate-TN study. This is an important study for multiple reasons. The Elevate-TN study basically was the study that compared acalabrutinib with chlorambucil and obinutuzumab That was the intent, that anything with chlorambucil is inferior to BTK inhibitor. Again, the same concept that chemotherapy was inferior to BTK inhibitors. And so this study was also designed for that particular reason of acalabrutinib in the frontline setting for patients who would not be considered candidates for chemotherapy. That study clearly showed that acalabrutinib was better than obinutuzumab and chlorambucil. The biggest issue with this study is now, and the most exciting part of this study is that this study had an arm of acalabrutinib plus obinutuzumab. Now, prior to this study, when it was initially coming out, there was this thought that if you combine rituximab to ibrutinib, as was done in the ECOG study and the Alliance trials, there was no improvement in outcomes. So the idea was that the addition of a CD20 antibody probably doesn't add much to the effectiveness of a BTK inhibitor. But as we know from this study, it's a pretty large study of more than 500 patients, that the addition of obinutuzumab actually is making a difference, and now the difference is almost 10-15% of progression-free survival. The study was not designed to look at that difference, but it's pretty evident now, and from other studies that we have seen, that rituximab is not the partner for a BTK inhibitor if you want to use a CD20 antibody. Number one, you have to use obinutuzumab if that's what you are planning on doing. So, and the addition of obinutuzumab clearly is now better in terms of progression-free survival for patients with CLL when you add it to acalabrutinib. So those are some of the important outcomes of the ELEVATE-TN trial. It was updated recently at ASH, and the difference is getting wider and wider between adding obinutuzumab and not adding obinutuzumab to acalabrutinib. That difference is there for all types of CLL except for 17p deleted patients. So except for the high risk, the worst risk patients, obinutuzumab addition is perfectly justified, and they do really well. So this is why if you are considering acalabrutinib, using obinutuzumab is not an unreasonable thing to do, because it allows your patient to have a longer disease-free interval. So moving on to the SEQUOIA study, this was again the most important study on zanubrutinib, which again was compared to bendamustine rituximab and clearly showed improvement in outcomes. So every way that you look at it, the BTK inhibitors are better than chemotherapy. Either it's BR, either it's FCR, either it's chlorambucil or obinutuzumab. So bottom line, chemotherapy has a very limited role for CLL, arguably no role for CLL, especially in certain parts of the world, and BTK inhibitors are here to stay. The addition of CD20 antibody to acalabrutinib makes sense. The data of zanubrutinib with obinutuzumab is not available, so it's hard to make any conclusions on that. So right now, when we were talking about our earlier recommendations of upfront treatment, if you notice that I had acalabrutinib with or without obinutuzumab as our preferred regimen, and then zanubrutinib by itself. So we have three drugs, ibrutinib, acalabrutinib. I already told you that we moved on from ibrutinib, but the big question is why? And is there a better BTK inhibitor? And the answer is no. Unfortunately, there are no trials in the frontline setting for patients who are treated with BTK inhibitors for us to clearly say which one is better. So that's why we do this analysis on patients who had comparative acalabrutinib versus ibrutinib in the relapse setting. So this is the ELEVATE-RR study. Now, this study was for high-risk patients only. Pretty large study for patients who had del11Q and del17P. So patients who had 17P deletion and 11Q deletion, and a lot of patients had unmutated IGHV, 2 prior lines of therapy as an average, and then half the patients got ibrutinib, half the patients got acalabrutinib. So high-risk patients getting both drugs. This is what it shows so far. If you look at the 2-year mark, which we were very excited about, around the 18 months to 2 years, we thought that ibrutinib would lose and acalabrutinib would win. But as you know now, after 4 years, the curves crisscross and there is no improvement in progression-free survival. Most of the benefit, or most of the fact that the curve went down with ibrutinib early on, was the fact that patients were having more toxicity and they were not able to continue ibrutinib, and that's why there was a drop-off early on. But this was very interesting and very important that the acalabrutinib and ibrutinib data initially had the separation of curves and then came down. So in another trial that was recently done, this was a completely different study, not the best study designs. It was designed to look at complete responses. And when there was complete responses, then the patients were further randomized to ibrutinib versus zanubrutinib. This was patients who had one prior line of therapy, all comers, including the high risk and the low risk. So different populations, so we shouldn't compare study to study. And this was also a very unique design, unusual design. But anyway, the study was done, and it again, and early on, showing that zanubrutinib is better than ibrutinib. Now, ibrutinib, most of the time in different parts of the world, is not performing as well as it used to in the past, because at least in the US, we have a lot of other options. So if my patient has a side effect to ibrutinib, we switch them to something else. So the chances of me continuing ibrutinib in the setting of side effect is very small, because I have access to multiple other BTK inhibitors. Now, in some parts of the world where we don't have access to BTK inhibitors, you can argue that patients will continue on ibrutinib longer, and those patients may have a different outcome. Regardless, any study in the future now, at least in the US, when it compares it to itself to ibrutinib, is probably not a reasonable assessment, because ibrutinib will be inferior in the future because of the fact that patients and physicians mostly are not inclined to continue with treatments, especially if they have other less toxic options. Zanubrutinib early on shows an improvement in outcomes, both in low risk and high risk patients. As expected, we need to have long-term follow-up and then see if there's any crisscross. So, as I said before, there is no best initial therapy. It all depends on what you want. Efficacy is the biggest concern, which there doesn't seem to be any major difference, and it's all about toxicity now. Luckily, our patients have a lot of options. But if you just put the PFS at 5 years next to each other, it looks like at this point, the 5-year outcome of acala plus obinutuzumab appears to be really good. Now, as if you remember, the median PFS with venetoclax and obinutuzumab is around 6-ish years. So this looks like, granted, obinutuzumab and venetoclax is a completely different concept of time-limited therapy. So that's another thing to consider. But if you just look at the 5-year progression-free survival, it looks to be the best in patients who are on acalabrutinib and obinutuzumab. For most of these drugs, the tolerability is pretty good after the first few weeks, and that's why most patients are able to continue for an indefinite period of time. There's also a concern that patients don't like to take pills. Some patients obviously don't like to take pills. Nobody wants to take pills. But for the most part, almost everyone in this world, or most people in this world, are on some pill or the other for high blood pressure, diabetes, or cholesterol, or aspirin, or something. So for most of our patients, as long as there is no issue with side effects, they're okay with taking a pill perpetually. So that's really not a major issue with BTK inhibitors in my experience. All right, so what about the high-risk patients? What do we know about that? Because like I said before, right now, the only thing that really matters is high-risk patients, del17p, TP53 mutations. So those are the patients that we have to really think about. All right, so BTK inhibitors, ibrutinib specifically, was approved based on a phase 2 study. That's it. That phase 2 study showed that the outcome was outstanding. And even after 5 years of follow-up, it still is looking pretty good. We are getting more than 5 years of remission in patients with BTK, which is impressive, which is really, really awesome. Because if you look at the outcomes of BTK inhibitors before, the outcomes of 17p deleted patients before BTK inhibitors came out, it was really dismal. And we were looking at a median PFS of maybe 11 months, 9 months, 13 months, in that ballpark. And it was very toxic treatment. The best thing that we had for 17p deletion was Campap. Since then, because of the BTK inhibitors and how effective they were approved right away. And we now also know that the addition of ibrutinib, or BTK inhibitors for that matter, is clearly the way to go as compared to chemotherapy. That's why we moved on from chemotherapy, especially in this group. There is really no reason to even consider chemotherapy in this group of patients. even if you want to use it on other patients. So this was the first evidence that came out with ibrutinib, and that changed the field forever. And now we have the ELEVATE study and the zanubrutinib study, the SEQUOIA trial. So both acalabrutinib and zanubrutinib has shown very promising effectiveness in patients with this really high-risk disease, and both of them are perfectly reasonable options to use in this setting. Now, as I mentioned before, you don't necessarily have to add obinutuzumab to acalabrutinib because the outcomes don't seem to be any different for this group. But for patients without 17p deletion, there is clear benefit of adding obinutuzumab. This is the CLL14 study. This is one of the reasons why, as I said before, we don't use venetoclax for these patients up front, is that the drop-off is pretty steep with venetoclax. And as you probably are familiar with some of the new data that came out, that even with unmutated disease, patients are not doing as well as with mutated disease when they get. So venetoclax treatment is not bad at all, but for patients who have 17p deletion or TP53 mutation, they don't do as well as patients without this mutation. So this is one reason when we do have a patient with those abnormalities, we don't start off with venetoclax. Obviously, if they fail a BTK inhibitor and the disease relapses, at that point, venetoclax becomes perfectly reasonable. We've talked a lot about the efficacy, and I've tried to convince you here that in terms of efficacy, all three options are very, very effective. Ibrutinib, acalabrutinib, and zanubrutinib. There is no clear winner so far. And I don't think there will be a clear winner because of the way the field is moving. Any trial in the future, even right now, any trial that shows that ibrutinib is inferior is, in my opinion, flawed. It should not be done because there is so much inherent bias against ibrutinib. Having said that, how do we discriminate? So there's three bleeding or safety issues that we have to focus on. Right now, the only debate is safety, safety, safety. And what are the three big ones? So one of them is bleeding, atrial fibrillation, ventricular arrhythmias, hypertension, and infections. All our patients get a lot of infections. COVID infection is here to stay. It doesn't matter where you are, but we are getting really good with vaccinations and treatments for COVID infection. But just like the flu, COVID is not going anywhere, and we still have to consider that issue. So infections will stay one of the biggest challenges we have for our patients because our patients are immunocompromised. Now, one point that I would like to make is that cardiovascular issues or cardiovascular toxicities are historically lumped into one category, which I don't think is the right thing to do because they have different etiologies, they have different pathophysiologies. So hypertension does not have anything to do with atrial fibrillation. In this particular instance, I understand that in other patients, so if you have hypertension, then your AFib rates and heart issues increase. But for the sake of this discussion, hypertension should be completely separate. Atrial fibrillation is separate. Ventricular arrhythmias are separate. And if people tend to lump all of these, but it's different. In patients on BTK inhibitors, atrial fibrillation happens within the first 6 months mostly, and then it tends to plateau, which clearly shows that it's not the hypertension that lasts for 2, 3, 4 years, and then they develop atrial fibrillation. It's not like that. So hypertension is physiologically unrelated with atrial fibrillation in this setting. Those are unique side effects of these drugs. So we will talk about them separately. We won't lump them into one. So that's the big take-home message. So this was the big trial with the Alliance and ECOG studies. So we've seen this now with multiple other studies. But one thing that was very obvious early on with ibrutinib was that bleeding was an issue, atrial fibrillation was an issue. But we also realized with large studies that in the older patients, especially above 70, the rate of sudden cardiac deaths were significantly higher in patients who were on ibrutinib. This has since been shown in other studies with ibrutinib. It is not, the signal is not there for young patients. So young patients typically do well, obviously, because they have a better cardiac function and cardiac health. It's mostly the older patients that actually tend to have this issue. Luckily, the numbers are still small of sudden cardiac deaths, but it's still unacceptably high. And that was another reason why, especially in the older patients, we moved away from chemo. So sudden cardiac deaths is an issue, most likely from ventricular arrhythmias, and it's seen in 70 years of age or older mostly, but occasionally also in younger patients. So in the ELEVATE study, in the safety analysis of the ELEVATE study, where acalabrutinib was compared to obinutuzumab, we saw the same thing. We saw a bleeding issue, which is still substantial. Luckily, the risk of severe bleeding is very small. Bleeding is a class effect, in my opinion. All BTK inhibitors, including pirtobrutinib, causes platelet dysfunction, and that's why bleeding risk is going to be there as long as you are on a BTK inhibitor. The other thing that we do know is that if you use antiplatelet therapy, those patients tend to have more of a toxicity with bleeding as compared to anticoagulation. So that's why we try not to use antiplatelet therapy like aspirin or Plavix. If we have to use DOAC like apixaban, it's actually easier to do that, and it's not that bad as long as you manage the bleeding risks with those patients. So somebody, for example, had a DVT, or for whatever reason, you want to keep them on a apixaban, that's perfectly fine. Similarly, if you have atrial fibrillation underlying, you can start a BTK inhibitor. It's not an absolute contraindication in those settings too. Sometimes based on the risk of the patient, you can use apixaban. Now, people ask me whether you use apixaban or rivaroxaban, and my answer is my preferred option is apixaban. Why? It's very simple. From rivaroxaban use, I tend to see more of the spikes because of the once-a-day dosing, and as a result, I see more of the blood blisters and bleeding issues with rivaroxaban as compared to apixaban. So that's why I use apixaban more exclusively. Actually, I don't use rivaroxaban in these patients if I have to anticoagulate them. But my biggest risk and challenge is with platelets, antiplatelet therapy with aspirin and Plavix. That's the one that I would definitely stop. All right, so that was about bleeding. In terms of atrial fibrillation, there's a small risk of serious AFib with acalabrutinib, and that's what we've seen with multiple studies now. It's a slightly higher risk as compared to the background patient population. Luckily, hypertension is not a major issue with acalabrutinib. Infections will continue to be a major problem for all our patients, and that's true for all BTK inhibitors. This is the Sequoia study. Sequoia study was the zanubrutinib study, which basically showed the same thing. Atrial fibrillation happens, but luckily at a lower percentage. Bleeding issues the same. Hypertension is also happening. Atrial fibrillation, ventricular arrhythmias, too low of a number, so we can't really say right now. And lastly, one of the more important things about zanubrutinib is the cytopenias, especially the neutropenia and the thrombocytopenia. So that's a bigger problem with zanubrutinib as compared to acalabrutinib, or ibrutinib for that matter. So this is kind of the head-to-head study with ELEVATE-RR, acala versus ibrutinib, and in this one, that the risk of atrial fibrillation was significantly lower in patients who were on acalabrutinib. Similarly, hypertension was also much lower in patients who got acalabrutinib versus ibrutinib. Acalabrutinib does cause headaches, which respond nicely to caffeine. It seems to be the best treatment. Luckily, most of the headaches are low-grade headaches, so it's relatively easy to manage. If you look at the curves now side by side with acala and obin, these curves are important to show because that's how you can visualize it. So if you look at the atrial fibrillation business, ibrutinib is significantly worse than acalabrutinib. Similarly, if you look at hypertension, acalabrutinib has a much lower incidence of hypertension as compared to ibrutinib, so very encouraging. Moving on to the bleeding events, acalabrutinib is better than ibrutinib, but I would still caution it's still around 30% of your patients. So I would take the same precautions with all BTK inhibitor. Diarrhea is better with acalabrutinib as compared to ibrutinib, and arthralgias are better. So across all of these few major side effects, except for acalabrutinib, appears to be better tolerated than ibrutinib. So I think it's pretty well established now that acalabrutinib is a slightly safer drug to use. And that's why we moved on from ibrutinib. Now, if you look at the zanubrutinib data, head-to-head with ibrutinib. If you look at the hypertension numbers, it's actually worse than ibrutinib. So is it a safer drug? That's debatable. Bleeding risk, again, numerically, slightly higher with zanubrutinib. So bleeding and hypertension is the same. Neutropenia, thrombocytopenia is almost the same with the ibrutinib and zanubrutinib. And then atrial fibrillation is definitely better. So again, we'll look at the same curves, and this is the curves. This is what they look like. For atrial fibrillation, zanubrutinib is definitely better than ibrutinib. For hypertension, it's the same, maybe slightly worse. Infection is the same. Neutropenia is the same, maybe slightly worse. So, is there a safer drug? That's the whole debate. So, based on these numbers, atrial fibrillation is better with zanubrutinib, but not hypertension. So, to make a blanket statement that cardiovascular toxicities are better or worse, I don't think that's a fair comparison because they have nothing to do with each other. Mechanistically, it's a different physiology, and that's why you have to look at these things side by side. So this is kind of how I put the numbers down. So on this left side, we put the ibrutinib and the Elevate RR studies, ibrutinib versus acalabrutinib. On the right side, I have the Alpine and zanubrutinib with ibrutinib. So, and red means the worst and green means the best. These are cross-trial comparisons. We don't do this comparison, but these studies will probably never be done otherwise. So for what it's worth, I've compared different studies to each other, and atrial fibrillation seems to be the best with zanubrutinib. Acalabrutinib is also pretty low. Hypertension is the best with acalabrutinib. Ibrutinib and zanubrutinib are pretty similar. Bleeding events are the same for all of them. Ibrutinib is worse, and then neutropenia is the worst with zanubrutinib. So this is what we have. So you decide which one you think is the safest one and which one you think is the most toxic one. In terms of effectiveness, I hopefully convince you that they're all pretty good.